On January 30th, 2020, the World Health Organization deemed the COVID-19 pandemic a public health emergency of international concern. What started as a mysterious pneumonia outbreak quickly devolved into an unprecedented human catastrophe that has only recently shown signs of slowing down. As we begin to turn the corner on the COVID-19 pandemic, we must acknowledge the severity and depth of institutional change needed to prevent something like this from ever happening again. Such changes are urgently needed in the U.S. healthcare system, which lost over $320 billion in 2020 as demand for routine services plummeted and failed the patients and communities that needed it most, exacerbating long-standing health disparities. One of the first most significant steps policymakers can take is to change how providers get paid. Historically, provider reimbursement has been based on the number and type of services delivered, allowing the system to twiddle its thumbs while underlying social drivers such as food insecurity and homelessness fester around it. Without financial incentives to improve health outcomes and quality of care, social determinants of health and the resultant health disparities will persist. Especially in a post-pandemic world, paying for value as opposed to volume can push the system to redefine health beyond the clinic and engage in targeted social care interventions. That being said, integrating health and social services is not easy. Health systems and community-based organizations have traditionally worked independently of one another, with distinct goals, values, and work cultures. Yet, in response to the rise in pandemic-related social needs, North Carolina was able to bring these two sectors together, building an ambitious community outreach and social supports program that made over 121,000 referrals to local resources and provided over 42,000 households with financial relief, food, medication, transportation, and COVID-19 preventive materials. The partnerships rapidly forged between the state, providers, and human services organizations offer numerous lessons for reaching marginalized communities, building service infrastructure, and scaling such models across the nation. Through the Healthy Opportunities Pilot, North Carolina has already begun to use value-based payment as a means to deliver social services to certain high-need Medicaid beneficiaries. Other states, such as Oregon, Massachusetts, and New York, have also embarked on similar initiatives, making our work in understanding the rollout of North Carolina's COVID-19 Support Services Program all the more valuable. What started as a temporary relief program can become the basis of a sustainable, impactful service delivery model that improves outcomes, cuts costs, and realizes social justice in health.